like to welcome you tonight and thank you very much for joining us. I am Barbara Daly. I'm with the Hispanic Chamber of Commerce and Mr. John Baines. He looks like a doctor, so we're going to promote him tonight. John Baines. John Baines, the Black Chamber and the Hispanic Chamber are your co-hosts this evening. And first of all, I'd like to introduce our panelists, and then I would like to also introduce our sponsors for the evening. Our panelists are Bill Trees from Blue Cross Blue Shield, and Steve Love from DFW Hospital Council, Liz BENAVIDES from Texas Women's University, Bob Garrison from CELTIC Insurance Company, and Dr. Robert SCHWAB from Texas Health Presbyterian. So we thank you, gentlemen, for joining us this evening. Thank you very much for being here. And our sponsors, the University of North Texas is one of our sponsors. Dr. Herman TOTTEN is representing the university tonight.
Dr. TOTTEN was going to give us a few words.
Oh, good. Okay.
As well as that.
Thank you very much for hosting.
Good evening.
Good evening.
It really is a pleasure for me to be here. And if you can remember, just about 2 weeks ago, the university unveiled its 4 bold goals for one great university. And that 4th goal was community engagement. And I represent that arm of that goal. So I'm just delighted tonight to be here and to say that the university is here. We're here to connect with the community. When you think in terms of needs in any area, give the University of North Texas a call first. Thank you very much.
Thank you for joining us. The City of Denton Public Library, Ms. Eva Poole, is also one of our sponsors this evening, and she provided us with this wonderful room. However, she is in Austin and was going to try to be back this evening, but she hasn't quite made it yet. So let's just give her a big round of applause anyway. And then DATCU is our 3rd sponsor, and Pat Sherman is here representing DATCU. So would you like to say something?
Well, we are delighted. We just celebrated our 75th anniversary, and we are your community credit union. One-stop shop for all your financial needs, but also we like to be a resource for the chambers in our community, and we are privileged to be able to sponsor this resource that's available to you tonight. Thank you.
Thank you very much. Mr. KERRY is the president of the Black Chamber, so I'm going to let him say a few words here.
We appreciate all of you all taking out of your busy schedule for this seminar. Again, we want to thank Eva Poole and the library, and also Jorge, you being in the Hispanic Chamber, for joining with us again. This is one of several multicultural events we do throughout the year. Thank the panelists, knowledgeable panelists. And we hope today you learn something from this seminar. It's going to affect all of us. We hope it make it a little clearer than mud. But we still know that there are things to be working and going on since the bill was passed, the law was passed in 2009. Everyone wants good health, but how you get good health? How can you afford good health? What is it going to mean to me as an individual? What is it going to mean to me as a business owner? These are some of the questions that we hope we have answers for you tonight. Do not hold back on your questions. That's what the experts are here for, to help you with those questions. Before we go any further, I noticed this is not a political event, but I noticed we have a couple of individuals in the audience that's running for political office. I'd like to just let them stand up and tell us who they are and what they're running for. And like John said, we have a busy schedule, so politicians make it brief for us.
I'm Bill Durant, I'm running for mayor, and that's the shortest speech I've ever given.
I'm Deborah Jones. I'm a candidate for Cheryl English, and I'm running for Denton ISD School Board Trustee, Place 1.
Is there anyone else in the room that is going to be throwing their hat in the ring? We do appreciate your willingness to serve our community. Elected office is not one that is taken lightly, and it's not one for anyone with a very thin skin. So, okay, I would also like to introduce Jorge. I know you're kind of under the weather. Do you want me to say anything, or would you like to say something?
I'll let you visit on behalf of the chamber.
All right, well, thank you.
Sorry.
Jorge is president of our Hispanic chamber, and I'm trying to fill his big shoes, which I don't do very adequately, but he's had some surgery and just not doing real well, but we're glad you're here and glad to see you up and around, doing well. Now what I'd like to do is just have each member of the panel reintroduce yourself and maybe give just a short 2-minute speech. Would please?
Sure.
We'll start with you again.
I'm Steve Love. I'm with the Dallas-Fort Worth Hospital Council. We cover an 8-county area. The Denton area is certainly within the realm of the Dallas-Fort Worth Hospital Council. In fact, Stan Morton, who you know is the Chief Executive Officer for the Texas Health Resource Presbyterian Hospital in town, served as our chair last year for the council, and he has been very active. A couple of things about the hospital council. We advocate on behalf of our 75 member hospitals. We have business and industry that's also a part of the council, and so we stay very close to some of the federal and state issues affecting reimbursement, patient safety issues, etc. for the hospitals. One thing I will tell you, we did commission a study last year to show the importance of hospitals in the community, because in many cases they're the largest or one of the largest employers. And within our 75 member hospitals, we account for 229,000 jobs, $12 billion in salary, wages, and benefits to the North Texas economy, $3.9 billion in retail sales, and $245 million in sales tax. To bring it home to Denton, just so you'll know, the 2 hospitals in Denton, 2,735 jobs, $146 million in salary, wages, and benefits, $30 million in retail sales, and $1.9 million in sales tax. So when hospitals speak, they're not only just talking about health care, they're also talking because they're large employers. It's a real privilege to be here tonight, and I'm very honored that you asked me to participate in this panel.
Thank you, sir.
Louis Benavides, the Associate Vice President for Human Resources at Texas Women's University. And last week I was notified that I'm going to serve on the Texas Medical Board in Austin. Kind of 2 hats. TWU, as many of you know, if you live in this community, half of our graduates are in the healthcare fields. So it's very important for us to keep abreast of what healthcare is going to look like, and what we can gauge and figure out for our students about what occupations they want to get into, and if they're going to be able to find a career, and a lucrative career in healthcare. The other hat is we're a large employer. We're one of the top 5 in the Denton County area, and we're sitting there looking back at the same law that you are, and trying to determine how it's going to affect the quality of healthcare for our employees, our faculty and staff. And so we sat there last week and budgeted $800,000 for healthcare increases next year. So it's a reality. It's something that we deal with, and that turns around, unfortunately, and affects student tuition. So there's a trickle effect when we talk about this particular law and the various aspects of it. So thank you for the invitation. I appreciate being here. Hopefully we can answer many questions that I know you have. Thank you.
Thank you, sir.
I'm Dr. Robert Schwab. I'm the Chief Quality Officer at Texas Health Presbyterian Denton. I also fill the same role at Texas Health Presbyterian Allen, so I spend a fair amount of time driving around too. I'm new to Texas. I've been here about 2 years. I'm going to tell you a little bit about my background so that it may help you if you're interested in certain aspects of this law. I think I have some perspectives that perhaps the other panelists don't. First, I'm a doctor, and I was a practicing doctor until 2 years ago. I'm now an administrator full-time. So I think I can give you some of the doctor's point of view. I trained in emergency medicine, spent most of my career in inner city safety net emergency medicine in Kansas City, which is like the Parkland of Kansas City. So I think I have a point of view about healthcare access that might be useful to you. At the end of my career, I changed from emergency medicine to palliative care, which is a big change. And I spent 3 years doing end-of-life care. So some aspects of the Accountable Care Act have been very controversial about end-of-life care. I may be able to offer you some perspective on that. And for most of my career, I've been heavily involved in quality and patient safety. And so I can offer you those perspectives to help frame your questions. Now I'm a hospital executive. I can give you that perspective, what this looks like from the hospital side. But as the others said, I'm very honored, and I thank you very much for having me. I'm looking forward to the conversation.
Thank you, Ben.
I'm Bill Trees, and I'm with Blue Cross and Blue Shield of Texas. We are the largest insurer in the state of Texas, representing about 1 in 3 who are insured with health insurance in the state of Texas. We're based out of Richardson, Texas. Our company, mother company, is Healthcare Service Corporation, and owns the Blue Cross and Blue Shield plans in 4 separate states. That would be Illinois, Texas, and New Mexico, and Oklahoma. I do represent the individual side of our business, not the group side. We are essentially a group insurance company, so I represent the smaller portion of our company, but with a different perspective than many from our company. So. Again, our company is based in Richardson. The mother company is actually based in Chicago. So let me just say a couple of comments related to healthcare reform. I think all the health insurance carriers were in favor and still are in favor of healthcare reform. We realize that the system is not perfect. That it's broke in some respects, and those issues and concerns need to be addressed. Even those inside the health insurance carriers recognize that and have always recognized that. To the degree that our company has put in over 300,000, up to this point, 300,000 man-hours involved in addressing healthcare reform and how we're going to react to healthcare reform and the impact to healthcare reform, and just making sure that we have all the minor details in place as this healthcare reform bill begins to roll out, and it's already begun, but some of the bigger pieces have yet to be rolled out. So we're definitely in favor of it, and of course, as we all know, there's a lot up in the air. And the debate has been hot, and in fact, the topic of healthcare reform will be addressed by the Supreme Court probably this summer. So, we're here and again supportive of reform, and I too, as the rest of the panel, am honored to be here and to help address this important issue.
Thank you, sir.
Hi, my name is Bob Garrison, and I'm here representing the Healthy Texas program, specifically CELTIC, which is an insurance carrier. But I am a broker. I live here in Denton, and I'm the guy that gets the phone calls from people like Lewis when their healthcare rates go up. So I'm sort of on the front line helping businesses solve those problems and answering the questions and trying to help the business community prepare for the future when healthcare reform fully takes effect. We actually represent all of the different insurance companies in our agency, but we are probably, if not the largest, one of the largest brokers in the Healthy Texas program, which I'm sure we'll talk about in more detail later. Again, I am very happy to be here, and hope I can help answer some questions.
Well, we appreciate our panelists tonight, We have a panel of very distinguished gentlemen that have a wealth of knowledge, and we appreciate your willingness to share with us. So, and now, Dr. John Baines, just got a promotion.
Well, Barbara and I are going to go through an overview of the Health Care Act in just a moment. But before I did that, I wanted to kind of lay a few ground rules. What we're going to do is we're going to push hard to get through a portion of the outline. And so if you have questions, please write them down on these cards. We will categorize the questions, and then we'll try to address the questions by category rather than stopping and starting again and again. We will stop promptly at 7:25, and then we'll have about 30 minutes to answer questions. So any questions you have, they will be addressed. And I would just simply like to say, welcome to everyone. Our goal is to have a non-political discussion. I personally am an independent, and I just want the facts, just like they used to say in that television show, just the facts, man, just the facts. And as a young person who started working at age 11, I was a paper boy from 11 to 14. I was a cook from 14 to 16, a grocery sacker, age 17, and I joined the Army, and I joined, I was a ditch digger and a meter reader from right out of high school for 2 years, and then I joined the Army. So I'm shaped in a certain kind of a way. And if we had a time, we'd go around and everybody could give their little story, and we're all shaped, and we're not all the same. So when we come to look at healthcare, all of those things shape the way we view things. And I don't think we'll ever arrive at 100% consensus, but we do want to find the things that are good for our community. And now we'll have Barbara, she's going to walk us through the does everybody have your booklet in there? It's called the summary. We're going to go through the summary. And we just want to walk everybody through.
Anyone need a booklet?
We will not get through all of the material tonight, but these pamphlets are for you to take home with and review. And so in case you missed something or we overlooked something, then you'll have some backup information for yourself. And as John said, we're all shaped differently. I didn't start to work till I was 14. And I was wrapping gifts at Christmas time for Marie Antoinette in Austin, Texas. And then I was a messenger boy for Western Union. Okay. Summary of the new health care reform law. Recently, two pieces of legislation, the Patient Protection and Affordable Care Act and the Health Care and Education Reconciliation Act of 2010 was signed into law. Together, these pieces of legislation make the most significant reform to health care in the United States since the enactment of Medicare. The Congressional Budget Office estimates by 2019, approximately 32 million currently uninsured Americans will have health insurance at a cost of $940 billion, close to $1 trillion. A major component of the reform legislation is the creation of a state-based American Health Benefit Exchange and Small Business Health Options Programs exchanges to provide health insurance for low-income individuals and small businesses.
So if you'll make note, that is a major item, is the creation of a state-based American Health Benefit Exchange and Small Business Health Options Program exchange to provide health insurance for low-income individuals and small businesses. That's a key component. Please continue.
Sounds like a bureaucrat wrote that. The following is a brief description of some of the most important provisions of the health care reform legislation. For individuals, U.S. citizens and legal residents will be required to have health insurance by 2014.
It didn't say illegal, it said legal. Legal residents.
With some exceptions. Those without insurance will face a tax penalty of as much as 2.5% of taxable income. Existing employer-sponsored health insurance plans will be allowed to remain essentially the same, except the plans will be required to extend dependent coverage to qualifying children through the age of 26, lifetime limits, and eventually annual dollar limits on coverage must be eliminated. Waiting periods for coverage cannot extend beyond 90 days, and insurers will not be able to deny coverage or change higher premium, charge higher premiums to people based on their health status or gender.
Okay, so once again, age 26, and it says lifetime limits. That means how much the insurance company will pay over a lifetime. Those have changed. Let's see. On coverage must be eliminated. So we've got some eliminated things there. I was talking with the people at Denton ISD, and they were telling me some stories about families that at one time with serious healthcare issues, it would have been capped at a certain level. But now those caps have been taken away, so they will be able to continue to have coverage, which is a new change to the tax law, to the healthcare law.
Medicaid eligibility will be expanded to include individuals under age 65 whose income is less than 133% of the federal poverty level.
Now, we're going to get the experts on the panel to talk about that number when we start going through some more material.
For families with incomes of up to 400% of the federal poverty level, tax credits and subsidies will be available to purchase health insurance through state-run exchanges and to offset out-of-pocket costs. Contributions to a flexible spending account will be limited to $2,500 a year. Reimbursements from health FSAs and HRAs for over-the-counter drugs will be restricted, and tax-free reimbursements from HSAs and Archer MSAs for over-the-counter drugs will not be allowed, while the tax on HSAs and Archer MSAs increases for distribution not used for qualified medical expenses.
It says the tax increases for distributions not used for qualified medical expenses. So there are these plans, and if you're pulling money out for non-qualified uses, then the tax for pulling that money out will be increased. So they're going to be more watchful on how monies are being pulled out and what they're being used for.
A rebate of $250 will be available to Medicare Part D drug coverage beneficiaries who reach the coverage gap, the donut hole.
We're going to talk about the donut hole. Anybody care about the donut hole? Okay.
And co-insurance rate for costs within the gap are gradually reduced to 25%. Adults with pre-existing conditions will be able to purchase coverage from temporary high-risk pools until 2014, when coverage cannot otherwise be denied for pre-existing conditions.
Anybody know anybody with a pre-existing condition? Raise your hand. Anybody? Okay.
A national program will be established to provide limited reimbursement for long-term care expenses for individuals who participate by contributing to the program's cost through voluntary payroll deductions.
So the beginning of this sentence says a national program will be established. And then at the end it says individuals who participate by contributing to the program's cost. So there's this program, but there'll be some benefit for those who contribute to that program. So this is related to long-term care costs.
Okay, that I just read the overview was for individuals. Now for employers. Employers with 50 or more employees that do not offer health insurance coverage will generally have to pay a premium tax of up to $2,000 per full-time employee. Employers with more than 200 employees will automatically enroll employees in health insurance plans for which employees may opt out. Employers providing health insurance must offer a voucher to qualifying employees to purchase insurance through an exchange. Qualifying small employers may receive a tax credit for providing health insurance to employees. I think somebody with the government wrote this. Okay, tax changes. The threshold for itemized deductions for qualified medical expenses will be increased from 7.5% of adjusted gross income to 10% of adjusted gross income through a temporary exception, though a temporary exception will be maintained for those 65 years and older.
So what's happening is, because of, I believe it's elective surgeries and things of that nature, instead of a hurdle of 7.5% of income, anything above that hurdle you get to deduct. But now the hurdle's been raised to 10%. Okay, so the hurdle is even larger to get over for certain income levels. If your income is above a certain level, then you get to deduct less. And but there will be some exceptions for those 65 and older.
Okay, thank you. A tax for Medicare Part A hospitalization coverage is increased to 0.9% for individuals with earnings exceeding $200,000 and for couples with joint earnings greater than $250,000.
So what's happening there is people that are in the higher income brackets will contribute more to Medicare. And so this is one of the changes that came as a result of this Healthcare Act.
Also, high-income taxpayers will be subject to a surtax of 3.8% of unearned income, such as capital gains, dividends, annuities, and rental income.
Okay, so people that are, once again, in the higher earnings brackets will be assessed a tax. Their tax bracket will have some additional taxation for certain items, and those items are unearned income, which is like interest, dividends, capital gains, rental income, those kinds of things.
The law imposes a 10% tax on the amount paid for indoor tanning services.
I guess I have to close my tanning salon.
No more fake tans. Some of these provisions are effective immediately, while others will be implemented over the next several years. Consult your financial professional to see how these laws may affect you.
Okay, go ahead.
Go ahead.
All right, thank you. Does anybody need a pencil or anything, or cards? If you do, just raise your hand. Let me tell you what I'm going to try to do tonight. There's no way, the original legislation was about 3,000 pages. So tonight we're going to try to cover the penalty, some employer issues, give you some examples, kind of wade in the water. This stuff is very technical. So I wanted to give everybody a taste of it. And then we're going to divert a little bit and allow these individuals that have varying levels of experience talk about changes in the areas where they are responsible, communicate, and then we'll come back to the end. And then we're going to have another session in May. We're looking at another session in May. If you go with me to the end of the outline, there are these tough topics here, like abortion costs, the rationing of health care, death squads, rising premiums, the role of Medicare in health care, the role of Medicaid, unnecessary surgeries and procedures, and other items. We're not going to try to get into any of that tonight. So that'll be for the next time. But tonight we want to just wade in the water, get your wading boots out, and we're going to look and see some of the materials. And you have to read this stuff slow. And so now let's see how we can do this. We're going to go to, in the very back, we've got this colorful document that's called Healthcare Incentives and Responsibilities. But before I do that, I wanted to ask the panel a question. There was a statement under the summary. It says, those without insurance will face a tax penalty of as much as 2.5% of taxable income. So one of the provisions, this is in the thing that Barbara just read, the very first sentence said, those without insurance will face a penalty. How are they going to find out who doesn't have insurance?
Falls under the purview of the IRS.
So this is a big issue.
My understanding is it's going to show up on your tax return in your premium costs. Yeah. If you don't have any, I guess.
Okay, so if there's on your W-2, but if you're self-employed, you wouldn't have a W-2.
Supposedly your provider will provide you something for that.
Your insurance provider.
Right.
And so if you don't have something, then that will be kind of a trigger that will give the IRS an indication that Dan Martin doesn't have insurance. But Dan's an insurance agent. So he's got lots of insurance. I'm just teasing.
So somehow you have to believe that it's going to be on the form itself. You have to, it'll have to be declared on the form. It's much the same as HSAs now. If anybody here has HSAs, HSAs are part of the current IRS document or documents.
Will they receive a notice from the IRS giving indication, a notice from the employer which is reported to the IRS indicating what you have?
There is a statement that you receive at the end of the year for what you've contributed into your savings portion, and also a separate statement that you get that relates to the amount of benefits that have been paid out.
HSA is a health savings account.
Correct.
Health savings account. Lots of acronyms. Sorry, Sir Bill.
Insurance world is full of acronyms. That's our life.
Okay, let's go to this colorful section here, and we're going to kind of wade in the water a little bit. It says here in that second paragraph, would you join like you need one of these? Because we're going through. Can we get a couple of outlines? We need 3 up front, please. Do you have one?
I can just look on.
It says, now this is an interesting statement, and this is made by CCH. If you'll notice there, I'm in the very back, in the next to the last one. I guess this is the last one, yeah. Healthcare incentives and responsibilities for small business. Once you get there, down at the bottom, there's this company called CCH. They're one of the premier tax companies in the world. So this is not my language. I just borrowed this off the internet, okay? All right. And it says, although the healthcare reform package does not mandate employer-provided coverage, see, this is interesting. It doesn't mandate it. It says the employers that do not offer minimum essential coverage to their employees or offer coverage that is deemed unaffordable will pay a penalty after 2013. So, as for example, they offer something, but they consider it unaffordable or unacceptable, then a penalty will be assessed. Okay? Next paragraph. It says, very small employers are exempt. Very small employers are exempt from the play or pay rules, but may obtain coverage for their employees in soon-to-be established state insurance exchanges. Could you gentlemen talk to us about those soon-to-be established state insurance exchanges, please?
Well, I'll just talk about Texas for a minute.
Please.
The state has to establish the state insurance exchange, and if they don't, then a federal program will come into play. To date, Texas has not established it. So it means that if they don't establish one, and some of the other distinguished panelists here may know more on this, it means the federal government will have to come in and establish that state insurance exchange.
So now, will the federal government be the insurer, or will they use one of our distinguished panelists to set up that insurance?
That's unclear, but it's my understanding that they will come in and be the catalyst to set it up, but they're going to offer it to all insurance companies that want to participate.
The government would just be the conduit, just kind of flow through the exchange.
Okay.
But, you know, the definition of the exchange is basically an area where a consumer can purchase, and employers can purchase health insurance in an informed way that will help really make the decision-making process much easier, in theory.
We're going to go to the next page.
Okay, John, I have a question. What is considered a very small employer?
We're going to get into that.
Oh, sorry.
Okay, we're on the way. Very good question. Once again, if you have questions, please write them down, and because I'm going to push to 7:30. Let's see. On the second page, it says, employer play or pay shared responsibility penalty. Should be very close to the top. Everybody see that? Okay. An employee, for purposes of the new employer shared responsibility requirements applied after 2013, is an employee who works for that employer on average for at least 30 hours per week. Okay? Then we're jumping down to the next section there. It says section 45R. It says Congress created section 45R, small employer health insurance credit, for two reasons. To help offset the cost to small businesses that offer health insurance coverage to their employees, and to encourage small businesses that do not offer health insurance coverage to start offering coverage. One of the reasons I invited CELTIC was I was at a presentation in Austin 2 years ago, and I heard them talk, and their focus was on small employers with 50 and below. Would you like to talk a little bit about this for a second?
Texas has been a little bit ahead of the curve. They actually created the Healthy Texas program before this federal health reform business really took effect. And it is essentially for small businesses under 50 and over 2. You have to have at least 2 people. To get group health insurance for their business at rates that are generally 30 to 40% less than a normal group health plan would be.
The premiums.
The premiums.
Premiums are 30 to 40% less.
Depends on the group. But the program was established by the state, and it is really under the sort of the oversight of the Texas Department of Insurance. And there are 2 health insurance companies that administer those plans. One is United Healthcare, and the other one is CELTIC. And you all probably haven't heard, or a lot of you haven't heard of CELTIC, but it's a company out of Chicago, and they do a lot of individual health insurance business elsewhere in the United States. So those 2 programs are available to business if they qualify. For a business to qualify, you have to have a business and have between 2 and 50 people. And we can't have had group health insurance for the previous 12 months. So they're basically uninsured groups.
So once again, a big point is these are people who haven't offered insurance previously. That's one of the requirements. They can get into this healthy insurance, Healthy Texas plan.
The other condition is that 30% of the employees in this business have to make or must make less than 300% of the national poverty level, which I believe is 32,500.
So if you take 300,000 and 300% of that would be times 3, right?
Yeah.
Times 3, right?
Yeah.
Yeah. So if you have 30,000 times 3, that would be 90,000, right?
No, it's the number is 32.5. I might have been wrong on the 300%, but 30% of the employees have to make less than 32,000.
But I was thinking the 300%. You said 300% of the poverty level. So what would that number be? What is that number?
I think that's 32,500.
32,500. So the people are making less than 32, and that's the average.
30% of people make less than 32,000 per year. The company qualifies for the Healthy Texas program. So if you have 100 employees, and 33 of them make less than 32,000, the whole company qualifies. And everyone can take advantage, even the other,
70.
Yeah, 70%.
It was
Who
2
make
to
more.
50. I thought you said 2 to 50 employees.
Well, yes, I'm sorry.
Yes.
Tried to make the math easy.
Keep going.
Once again, we're waiting. You see how technical it is. It's got a lot of numbers and this and that. It's not simple. It's not simple. Let's talk about the maximum credit for just a minute. At the bottom of the page there. It says, and this is so for people that offer, for employers that offer the premiums, they get a credit against their taxes. Okay? So we're going to talk about the maximum credit. Let's just walk through it here. Their words are much better than mine. It says the credit is provided in 2 phases over a 6-year period. The first phase of the credit extends from 2010 through 2013. The second phase of the credit applies in 2014 and 2015. And while I'm thinking about it, I was told that one of the things we read in the summary no longer applies. What was that you indicated on the
long-term care.
The long-term care that we spoke about has been eliminated, that whole provision. So once again, I'm a novice up here. I just look good, but but I don't know everything. This is why I have the panelists here. Okay. For tax years beginning in 2010 through 2013, the maximum credit is 35% of the premiums. We're going to go through a couple of examples to make it clear to you. And 25% of qualified premium costs for tax-exempt employers. For example, it would be like a DATQ is tax-exempt. So you get 25% of the qualified premiums would be qualify for a credit if, depending on the size and number of employees, there are a number of things. But you're a not-for-profit versus another business that's a for-profit. So they've got different percentages. Okay? The maximum credit for the tax years 2010 through 2013 is available to qualified employers having no more than 10 full-time equivalent employees and paying average annual wages of $25,000 or less. Additionally, the employer must pay the premiums under a qualifying arrangement. Let's look at the example right there. It says Belt Company. Belt Company is a small manufacturer. Belt employs 9 full-time employees with average annual wages of $23,000 for each full-time employee in 2010. Because the company employs no more than 10 individuals and pays average annual wages of less than $25,000, Belt is eligible for the maximum 35% credit. Okay, in 2010, the company pays $72,000 in healthcare premiums for its employees. Belt's credit is 35% times $72,000, which equals $26,200. What that means is, whatever that corporation owes, let's say the corporation owes at the end of the year $50,000 in tax, then this credit will reduce their taxes by that much. They'll get a credit against their income taxes. And this is an incentive for employers to pay for health care benefits. Any comment, gentlemen? Okay. We're going to do a couple more, and then we're going to deviate from the outline a little bit. Let's see. We're going to go to the next page. And once again, I'm just trying to give you a taste. You have a booklet so you can go home and read, put yourself to sleep, wake up and read some more. But at least you're getting an idea of what's included in the healthcare plan. Okay? All right, example, strapping company. I'm at the bottom of the page. At the bottom of the page, strapping company. Has 12 full-time employees and pays average annual wages of $30,000 in 2010. The company pays $96,000 in healthcare premiums for those employees. So who can tell me what 12 and the 96 is? 8. So it's $8,000 per employee, okay, for premiums that are being paid. Okay? Assuming that Stratton meets all the requirements, then they get a credit as follows. 35% of that 96,000 is $33,600. So they would get a credit against their income taxes of $33,600. Jumping over to the next example, it says Tuck Company has 15 full-time employees and pays average annual wages of $34,000. They go down and they get a tax credit of $12,880 against their taxes. We're going to switch gears here for a minute, and I'd like the two gentlemen from the hospital to tell us. You can kind of see, Barbara gave us an overview of what I have to cover, but I'd like for these gentlemen with the hospital to talk about 5 minutes apiece, about some of the changes that we can anticipate in hospital care, hospital costs, and hospital matters as it results to the Healthcare Act. Please.
Sure. Hospitals welcome a lot of the changes that come through the Affordable Care Act. Let me give you a great example. In many cases, what we've dealt with is being paid a fee for service, being paid for doing something. And coordinating care, which hopefully will come from this healthcare reform, is in the best interest of the patient. For example, let's assume someone has diabetes. If they come to the emergency room and then they're treated because they have a problem where they have to have a toe amputated, that is the wrong place for treatment to start. You need to go back to prevention. And I'll defer to Robert to get into more of those clinical and quality issues. But the one thing in healthcare reform that is a challenge, and we've talked about coverage, is access. And let me define the difference between coverage and access. You've heard a lot about the Massachusetts plan. 97% of the people in Massachusetts have had coverage, and that's excellent. And again, we're not Republican or Democrat. We treat all in the hospital. But the problem is access, and by access are there physicians, primary care physicians, where people can go and receive treatment as opposed to going to the emergency room. And even in Massachusetts, 2 of the largest public hospitals almost went bankrupt because the people now with coverage flocked to the emergency room because they didn't have primary care physicians. And there's a shortage of primary care physicians. So we welcome the increased coverage from a hospital point of view. But what we really want to continue to focus on is how do we give the best access.
Now, Steve, you're saying that the problem is there's not enough doctors?
Yes. Doctors, for example, in the state of Texas on Medicaid, and Medicaid general is for children, pregnant women, and disabled adults. 1/3 of the physicians accept Medicaid. 2/3 don't. You may say, well, why don't they? Because the Medicaid payment formula is so low, it doesn't even cover the physician's costs. So part of the problem is increasing the coverage is one thing, but providing the correct access is another. And so that's one of the things we want to work on. From a hospital perspective, we do agree we need to coordinate care better. We need to do better in preventive medicine. We need to do better in after care and follow-up. For example, as you see in 2014, there's going to be a penalty to hospitals on the Medicare side if you have a readmission within 30 days.
So you treat someone, but they didn't get it right.
Right. But why didn't they get it right? It could be that there was a problem, okay? But let's assume that person had congestive heart failure, and they went home and didn't take their medicine, continued to smoke, and didn't do anything the provider or the hospital asked them to do. They had a relapse and they're readmitted to the hospital. Now, whose fault is that? Now, these are some of the challenges we have to deal with, but there are a lot of good things in the healthcare reform. Coordinating the care, working collaboratively together, but we need to focus on responsibility and assign that responsibility for the patient. They're the largest stakeholder. And then coordinate with the physicians, coordinate with the hospitals. So there are a lot of things in the coverage that are really good, and the timing. And this is important to Texas. It's unfortunate. Most people may not know this. Texas is ¡1, and this isn't a good statistic. We're the #1 state in the nation with the highest uninsured. 27% of Texans have no insurance. When you walk down the street, 1 in 4 of your fellow citizens have no health insurance. So this is a big problem. So extending the coverage is a very good thing. But how do we match that with access so that we can get the type of treatment in the appropriate setting that the patient wants? So hospitals welcome the healthcare changes. We just want to make sure that we can deal with some of these issues, especially with access. Robert?
Well, I think I agree that we welcome them, although I'm not sure how it would be different if we didn't, because they're coming, whether we like it or not. So hospitals are really engaged in two things now. One is doing what we've always done better. And what we've always done is not health care, it's sick care. Our system, we don't have a health care system, we have a sick care system. We don't spend a lot of time and money on health, we spend it on sickness. And so hospitals were in the business of taking care of people when they got sick. In the New World Order, they'll be asked to try to work hard to keep people out of their place of business. So for those of you who own a business, you can imagine what that feels like. If you, let's say you ran a tire store and all of a sudden you were told that your job is to keep people from buying tires. You would have a difficult time imagining that, and I think hospitals have had trouble imagining this. And this is really the accountable care organization piece of this, which is an ill-defined collection of doctors and hospitals and nursing homes and other post-acute care facilities, allegedly all working together for an episode of care, which is defined vaguely, but one episode, for example, I have a knee problem right now. So an episode of care would be the care of my knee, from primary care doctor through radiology, through seeing a specialist, through imaging, whatever else I needed, surgery, rehab, all of that would be one bundled episode of care that's somehow paid in a bundle and doled out in some ill-defined way. And I'm really not trying to be glib or smart-alecky, that's really what the proposal is. So partly we're in the business of trying to figure out how to be a tire store and not sell tires. And the other part we're trying to do is do what we've done, only better. And so things like core measures, which you will hear about, that is a snapshot surrogate for quality in healthcare. Because if you ask people what is quality in any realm, it depends on who you ask. You know, quality might be a $75 shirt if you're shopping at Nordstrom. But a $75 shirt at Walmart would not be considered quality, because that's not what they sell. So it depends how you define it, and what the government has done is taken a collection, a small collection of important measures that they can manage and that means something both to them and to the public, and those are the core measures. That's our surrogate for healthcare quality, and we're evaluated as to how we do, and we have been for a number of years. Initially, when they started it, they said, these are some measures. If you'd like to report them, that'd be swell. If you don't want to, it's okay. And as you might guess, some people did it, most people didn't. Then they said, it's up to you whether you report them, but if you don't, we're going to hold back a little bit of Medicare. And as you might guess, everybody reported them. And now we've entered the era of value-based purchasing, where Medicare no longer becomes a payer, but they're a purchaser of services. And we're reimbursed not only for reporting them, but for how well we do. So core measures, if we fail, it comes out of our pocket. Customer satisfaction, if we fail, it comes out of our pocket. There's nothing to argue about with that. Core measures are things we ought to do. Customer satisfaction is an important thing. More and more hospitals will look like hotels, because that's what people want. So there's really not a lot to argue about, but it is important to understand that it's a sea change for hospitals in trying to figure out how to keep people out of the tire store.
What do you mean a sea change?
Well, it's just never been what we did. Our job was to take care of sick people. And when you showed up, we took care of you and we got paid for doing so. Now we're going to get punished if you show up again. You know, it used to be, not that we wanted the revolving door, but if a patient came back, it was another episode of care and we got paid. And by the way, physicians get paid that way still. So it's a real sea change for hospitals trying to adjust to that. And people ought to be aware of it. That kind of change doesn't come easy. I mean, these are tough times, and hospitals are already struggling, for the most part, with their margin. You know, hospital margins are razor thin, and don't think for a minute that if that margin goes away, hospitals will absorb the loss. What will happen is your grandmother will have one less nurse, and that's not in anybody's interest. And so, you know, and you didn't ask me about this, but I'll say it anyway. In a state like Texas with no certificate of need, where there are a lot of joint venture hospitals and physician-owned entities and ambulatory surgery centers, those tend to siphon patients away from hospitals that are the best patients. They're young, they're healthy, they don't get into trouble. That leaves the hospital with the oldest, sickest patients to take care of. They're the most costly and the hardest to do right. So that may not seem like a big deal to you until you realize that when your loved one gets really sick or really hurt, there is no ambulatory surgery center or joint venture hospital on earth that will take care of it. That's the community hospital. And community hospitals are a community benefit. And it's not in anybody's interest, in my opinion, for hospitals to struggle to make a small margin.
Just as I.
Yeah.
Yes.
Just a couple of things I'd
Sure.
like to add to what Robert said.
And after, and when you do that, then Lewis, I want you to talk about some of the issues that we did not include here that affect large employers. And then we're going to come to the two insurers, and we're going to have them talk about some of the things that are not included here that the audience needs to know about. Thank you.
Yeah. To follow up what he said, hospital margins continue to be compressed. A lot of people don't know this, but when the law was signed in 2010, hospitals through the American Hospital Association, trying to be a catalyst for this, agreed to $155 billion in cuts over a 10-year period. Hospitals sat at the table and said, we'll give up $155 billion. We had cuts to Medicaid. In the last 18 months, the state, to help balance the budget, has cut Medicaid 10%. In addition to that, because there was not an agreement reached by the special committee, on January 1 of 2013, we faced an additional 2% cut to Medicare through sequestration. And the Middle Class Tax Relief and Job Creation Act, which President Obama signed into law on February 22nd, cut yet another $160 million from hospitals just in Texas. So the margins at hospitals are being compressed tremendously.
So eventually that's going to come back to bite us. Lewis?
One of the issues from an employer perspective is the cost structure, just the cost of both sides of the house. The employer is responsible for X amount of expense related to health care, and we're seeing some of the promises of controlled costs not being realized. And we're passing that on to students in form of tuition. That's passing it on to parents, taxpayers on federal assistance. And on the other side, from the employee has to pay a portion of their health insurance. And what you've seen is co-pays going up, annual co-pays, the amount that you pay your physician, every time you visit your physician, you're seeing that go up from, it should be $20 to 25, 30, now it's up to 40 if you want to see a specialist. You're seeing it being passed along more and more to the people utilizing healthcare. So we're seeing
do you have a self-insured plan, or are you using a device?
Yeah, we're using a provider.
And then
we go through the state of Texas, and the state of Texas negotiates these, and so they try to keep the cost down, just like he was saying about the Medicaid being cut across 10%. Well, that's applied to the state in terms of controlling their costs. And
But
so
still, you're seeing
it's
these
being passed
co-pays.
on to
You're still seeing the
individuals.
co-pays
Right, it's being
increase.
passed on to individuals. So where we're concerned, what we don't see in here, and we've all had elderly parents to tell you that nothing is for free. And there's a lot of stuff that's free in this act, free tests and things like that. Well, those costs are going to be provided, passed on, and we're all going to pay for that. And so we've got to focus on the cost containment piece of it and controlling that.
Thank you. Gentlemen? The insurers?
Do you have a specific question?
Well, you can kind of see where we're going with the material. And I was wondering if you wanted to kind of take this opportunity to kind of give the audience an idea of some things that you're aware of that would not get covered if we just went line by line by line.
Let me just say that the current law, the way it's proposed, it's similar to the federal employee program. Maybe we can talk a little bit about that, and then we can start there, and then if there are other thoughts that come in. But the proposed benefit structures will have, that will have to be included on the exchanges, and this will be the public exchange that we were referencing earlier. There will be a bronze, a silver, a gold, and a platinum package. Benefit structures will be able to be established anywhere between this minimum and the maximum. And this is for the public exchange. At the same time, there will be a private exchange. So the public exchange is the only place where you'll be able to go and purchase health insurance with a subsidy. You were referring earlier that there will be subsidies available to folks up to 400% of the federal poverty level. And that
Help us with that number. So when you
the
say
best estimates are that would be a family of four earning up to $88,000 a year. I mean, that includes a lot of people. A lot of people.
So they'd be qualified for a subsidy.
For a subsidy of some sort. It's a graded subsidy, so the more you make, the less it's going to be.
Yes.
At least, again, that's the theory right now, based on what you can read in the law. Then there will be, and guesstimates are, there may be roughly 40% of the buying public who will be able to purchase through the public subsidy. The balance would purchase through private subsidies, or private exchanges, I'm sorry, which will be established very much in a similar way, online, by the way, online. So this public exchange will be an online method of purchasing insurance. And if you want to use your insurance broker, you would have to go probably to the insurance broker's office and view all this online, or talk over the phone and see this online. But you'll have the minimum maximum packages that will be available through the public exchange. Then there will be the private exchange, and a multitude of other programs will be available through the private exchange. You know, will HSA still be available? When we talked about the cost of care, well, you know, I think you can make a good case that part of the reason why we're in the situation, or healthcare is in the situation it has been, is because health insurance programs have been covering everything. We're talking about copays, some zero copays. You go zero deductible, zero copays. That kind of got us in the initial problem, or started down the wrong road. I mean, I've heard the analogy, it's like, maybe it should be like auto insurance. I mean, your auto insurance doesn't necessarily pay for replacement of tires, oil changes, some of the basic stuff that you have. You're required to come out of your own pocket with that. But it covers the big expenses, right? Maybe health insurance should be the same way. And health savings accounts, I have owned an HSA plan myself for going on 5 years now. They're designed to get the consumer more engaged in the buying process for healthcare. Because when there's a third party picking up all the costs with a little copay and little co-insurance, you're going all the time.
So one of the problems is, I hear you saying, is that the way the system has been for years is it's been doing too much or paying for too much.
You can make that argument.
Okay. There are some that make that argument.
Yep.
Well, I'd add to that, that's true, and it's also paying for the wrong too much. it pays for specialty care more than it does for preventive care, which I don't think we ought to pay for too much of anything. So I agree with Bill. But I would say that not only are we paying for too much, but we've tilted it towards specialty care and procedures rather than preventive care that would result in a healthier population.
Mr. Garrison?
Well, I maybe expand a little bit on the whole consumer-driven healthcare initiative, which is the HSA qualified plans. It is a great way to reduce costs because people become shoppers of their healthcare, which is what we were talking about.
So one of the things you're saying is we need to change the system so that people are limited in their selection or their choices?
No. Consumer-driven health plans, or these HSA high deductible plans, as it is quoted,
Okay.
are for people to pay the small things, to do the tire changes and the oil changes, or pay for the small medical expenditures out of their own tax qualified account.
So they're paying for the little stuff?
They're paying for the little stuff.
Okay.
The insurance company is there to pay for the big stuff,
Okay.
for more catastrophic kind of care.
Okay.
But what it allows the consumers to do, instead of just going in and say, I have insurance, it's going to pay for everything, it allows the consumer to call up and say, how much is it going to cost me to have my knee x-rayed?
Yes.
One place over another, much like you would if you're taking your car in to get it. So, I mean, I think there's a lot to be said for that particular mechanism. That if it were being used widespread, could control the cost of medical.
So is that something that we see in the new Health Care Act, or is that something that needs to be included?
Well, we don't see it. It hasn't been taken out of the Health Care Act, from what I understand, but it's certainly not the prime objective. Would you agree?
It's not prominent. It's not prominent. It's not prominent.
You know, just to give you an example, there can be a pretty big variance in the cost of an MRI, depending on which place that you go to get an MRI. And if a doc orders an MRI, and I had a situation like this where a doc requested an MRI for my daughter a year and a half ago. It was not an emergency situation, and I asked him if it was absolutely necessary, and the end result was no, it wasn't absolutely necessary, and he may have been ordering it from a defensive standpoint. You know, we have a lot of defensive medicine going on these days.
So I won't get sued, right?
Correct. Yeah, correct. So he agreed it was fine not to do it, so we avoided the cost altogether. I have an HSA. I probably wouldn't have done that had I not had an HSA. It engages you more in the process.
Yes, Louis.
Yeah, the problem in the act is there was no tort reform at all in the Black. So you're going to have a lot of this testing that's going to continue. You know, and it might be, some people call it excessive testing or things like that. I had a question for the audience. If you could raise your hand if you have insurance that has no deductible and no copays. So, you know, the majority have, you know, some sort of contribution that they've got to contribute, and who have seen that either increase the last 2 years? Good, that's good information.
Okay, we're going to jump back into the, we've got to stop at 7:30 so we can have the questions and answers from the audience, give you a chance to have your input. We still have a few minutes. Just raise your hand if you have a card. We're going to need, Barbara, can you begin to categorize those for us? Let's go back to the colorful page. We're going to go to page 6. To page 5. And let's see. These are excluded employees when it comes to dealing with the credit. So if you want to pay premiums and get the credit against taxes, not all wages will be considered deductible or included in that formula. We're going to look at some of the ones that are not included. It says excluded employees for FTEs and annual wages. Jumping down, owners are excluded. So when coming up with that calculation, the owners are excluded from the calculation of full-time employees. Sole proprietors, partners, shareholders, or any person owning more than 5%. Family members that are on the payroll are excluded. Children, siblings, parents, step-parents, niece, nephew, aunt, uncle. Dependents are excluded. And then we want to look at the hours of service. Not only do you look at who's excluded, how many hours are necessary to be a part of that calculation. It says employers must determine the number of hours of service performed by employees. The IRS has provided 3 methods that employers may use to calculate the total number of hours of service that may be taken into account for an employee for the year. Actual hours of service, days worked equivalency, and weeks worked equivalency. Let's look at Priscilla down below at the very bottom. It says Priscilla worked 48 weeks, took 3 weeks of vacation, and took 1 week of unpaid leave in 2010. Priscilla's employer uses the weeks worked equivalency method to calculate the total number of hours of service. Using this method, Priscilla would be credited with 2,040 hours of service. Okay. Go on to the next page. Premiums. Only premiums paid by the employer under a qualifying arrangement are counted in calculating the credit. In calculating the credit for a tax year in 2010, an employer may count all premiums paid in the year, including premiums that were paid in the year before health care was enacted. Let's see. Paid in 2010 in the year before health care reform package was enacted on March 23rd, 2010. Under a qualifying arrangement, the employer pays premiums for each employee enrolled in health care coverage offered by the employer in an amount equal to a uniform percentage, not less than 50%, of the premium cost of the coverage. If an employer pays only a portion of the premiums for the coverage provided to employees under the arrangement, the amount of premiums counted in calculating the credit is only the amount paid by the employer. So the employee's portion of the premium doesn't get included in the calculation. Only employer's portion gets included. And then healthcare coverage for the purposes of the credit includes the following types of coverage: dental, vision, long-term care, nursing home care, home health care, community-based, and any of the above. And let's see here. I'm going to go over here. We're going to talk to the insurance people just a moment. We're going to talk. It says, on average, it looks like the state of Texas has 2 averages that are about, I think they're going to kind of monitor how much you can put in there. You can't put $100,000 in there worth of premiums. So they're going to kind of manage the amount that you're looking at. If you look at the table on the next page, this is on page 7. There's one category, one column for employee only, and then for family coverage. So it looks like the this is going to be the average premium that will be used. Now let's look at an example at the very bottom using this, and then we'll go on to another topic. Okay. It says, example, Gorston Company offers a health insurance plan with single and family coverage. Gorston has 9 FTEs, full-time employees, with average annual wages of $23,000 per employee. Alan, Brenda, Kerry, and Dustin are enrolled in single coverage. Eve, Freddie, Jeff, Hilda, and Jenny are enrolled in family coverage. Annual premiums for single coverage are $4,000, and the annual premiums for family coverage are $10,000. The company pays 50% of the premiums, of all employees enrolled in single and family coverage. The average premium for the small group market is $5,000 for single coverage and $12,000 for family. ABC premium payments for each FTE for single coverage of $5,000 for family do not exceed the percent of the average premium for the small group market in its state. The amount of premiums paid by the company for purposes of calculating the credit, 4 times $2,000 and 5 times $5,000, for a total of $33,000 worth of premiums that would be used to calculate the credit. So let's say a person wants to provide insurance, and then they want to get the credit for providing insurance, then this is the number that they would use. We're going to go back and hit just a couple of other items, and then we'll take questions that have been turned in. Let's look at section under, it's called RIA, Analysis and Tax Benefits. A lot of white space here. It's the tab right in front. Where we were. And having this dialogue with people, you use the car insurance example, that do we penalize people for not having car insurance?
There's a law, if you own a car. If you own a car, that's the catch, you know. Not everybody owns a car.
Okay.
Most people do.
Okay, but those that own a car, if you operate without insurance, then there's a penalty.
Unless you can afford
Unless you can.
afford otherwise. You can.
Self-insurance.
Self-insured, unless you're.
So that, let's say, for example, if I self-insure and then I have an accident, then I'm responsible for paying for the repair costs to someone's Ferrari or Corvette.
You have to show proof you have $85,000 in the bond, but that's the minimum limit
For self-insurance.
self-insurance.
Okay.
60 plus 25.
Okay. So using that as an example, there's a big question as to whether people should be penalized for not providing health care coverage. There is a penalty for not having auto coverage. The question then is, should people be penalized? We're going to go through the Penalty Act here a little bit. On page 1 of 9, at the bottom, it says, penalty for remaining uninsured. Okay? For tax years ending after December 31st, 2013, non-exempt U.S. citizens and legal residents, not illegal residents, legal residents, will have to maintain minimum essential coverage or pay a penalty. Those failing to maintain minimum essential coverage in 2016 will be subject to a penalty equal to the greater of 2.5% of your income, your household income, or $695 per uninsured adult in the household. So if a person has no insurance, there's going to be a penalty assessed, and let's say, help me with this, once again we talked about people knowing that they don't have insurance. So once there is a record that this individual does not have insurance, then a penalty will be assessed. Is it from the government, or will they have to do a self-reporting on that?
Well, I'm not sure what the rule is, but I can tell you the bigger penalty will be paid by the hospital. Because what will happen is no private physician will see a self-insured patient, so they'll get their care in the hospital emergency room. Or they'll get sick and be admitted to the hospital because hospitals are not allowed to turn people away. And so the bigger penalty will be paid by the hospital.
So why do you say the bigger penalty is paid by the hospital?
Because the cost of providing care to that person is far in excess of $695 a year.
So the thought is, and I'm not anywhere other than just trying to understand, but let's say the $695 then would go to the federal government to go into a pool of money to help pay for all of the reform. That's the goal. Is that correct? So forcing everyone to pay a share of the cost of coverage. Yes, Steve.
The other thing, and you heard earlier, who's tracking this? The Internal Revenue Service. It's my understanding you're CPA.
Yes.
And do you do tax returns?
I do a few.
Does everybody file taxes?
Not everyone.
So, there you go.
But also, to let you know, it was recently noted in the news not too long ago that as part of healthcare reform,
The IRS is in the process of hiring 16,000 additional IRS
Agents.
agents.
In anticipation of monitoring this,
That's exactly.
along with
Just,
logistics, I mean,
to let you know that that's exactly one of the 4 issues before the Supreme Court. So we're going to get a definitive answer on this, probably this summer, on this individual mandate piece. So,
forcing people to have insurance.
yeah, that's why the 4 issues are going to be decided by the Supreme Court.
All right, let's go to the next page. I'll allow you to read at your own leisure the low-income tax credit for participating in health exchanges, but I want to talk about employers' responsibilities. So on page 2 of 9, do you have one of these? Okay, good. It says employer responsibilities. For months beginning after December 31st, 2013, an applicable large employer, that's generally one that employed an average of at least 50 full-time employees during the year, not offering coverage for all of its full-time employees, offering minimum essential coverage that is unaffordable, so they offer something but it's unaffordable, or offering minimum essential coverage that consists of a plan under the plan's share of the total allowed cost of benefits is less than 60%, will have to pay a penalty if any full-time employee is certified to the employer as having purchased health insurance through a state exchange, with respect to which a tax credit or cost-sharing reduction is allowed or paid to the employee. The penalty for any month will be an excise tax equal to the number of full-time employees over 30 employee threshold during the applicable month, multiplied by 1/12 of 2,000. So every month there's a $2,000 penalty for not providing insurance if you're an employer with over 50 employees. Would you gentlemen like to talk about this a little bit?
Well, as a business owner, with over 50 employees, this is going to be, it's going to impact the bottom line. There's no doubt about it. Unless they currently offer group health insurance. So it's you know, those costs are going to be then passed on to the consumer. It's the trickle-down effect. But it is somewhat onerous.
So what would be an option? What would be an alternative to such a thing?
Let me go back just one point, if I can.
Sure.
I wanted to talk about the individual mandate, assuming that the Supreme Court doesn't strike that down as unconstitutional. If you are a 25 to 30-year-old, and let's just assume that your earnings are up there, so you're going to pay the maximum $695 penalty per year if you don't buy health insurance. But you're 25 years old and you feel like you're pretty well bulletproof. The average, and who knows what the cost will be when this all comes to fruition, but let's just assume it's $200 a month for a qualified health plan. That's $2,400 a year that person's going to have to spend versus the $695 penalty. I'm not sure that's enough of a penalty to make that 100% insurance level or 97% insurance level.
Yes, Steve.
And then going back to time, what Robert said, let's assume it's not enough penalty and they choose not to do it, but they have some severe illness. They're going to come to the emergency room and the hospital's going to pay for it.
Well, so we have all these uninsured people. I had a conversation with a gentleman about 6 or 7 problems. We used to call them simultaneous equations. And we have to solve all of these different problems at the same time, and it's not that easy. So we've got the uninsured, but if we move forward, is this going to knock our healthcare system? Is it going to damage it if we continue this way? If we don't have the money to pay for if we're forcing costs on the hospitals that are not being reimbursed, then we're decreasing the level of care. The physicians don't want to do the work anymore. They're not honoring Medicare, Medicaid. So it just seems like we're really at a crossroads here as to what we need to do.
Well, the iron triangle of healthcare is cost, access, and quality. And so, traditional public health teaching is you can get 2 of the 3, but you can never get 3 of the 3.
So what's the triangle again?
Cost, access, and quality.
Okay.
So if you're going to improve any one of them, it generally comes at the expense of at least one of the other. And so, we've ignored access, basically. We've worked on cost, not very effectively. And we have worked on quality, I would contend, reasonably effectively. But now we're adding access. That's what we're talking about. And we're trying to say we can increase access to universal, we can continue to improve the quality, and we can lower the cost. I don't know whether we can. It's a daunting challenge, but that's what's before us.
Well, we're almost at 7:30, so to keep us on schedule, we do have some questions that need to be posed, and we'll pose the questions, we'll hear from the panel, and then we'll make our closing remarks, we'll make announcements, and then we'll look forward to seeing everyone again in May. So without further ado, we have a question.
Thank you. This plan will attempt to provide more primary care and less emergency room care. The result will be less margins for hospitals and more demand for primary care physicians. How do we keep hospitals afloat, and where are the primary physicians going to come from? Yes, sir.
Yeah, I'll take the first shot at it. Texas is unique, and a lot of people don't realize this. We have some excellent schools, don't get me wrong. We train a lot of physicians in Texas with all our surrounding states. We don't have enough residency programs. I'm certainly not a physician. Robert can address this. But there's a phenomenon that most physicians reside in open practice within 50 miles of where they do residency. We train a lot of physicians here in Texas, and they go out of state to do their residency, and they don't return. So we've got to look at how we change that. That's a public policy issue. The other thing associated with it, and I hope I don't step on any toes, but when you go into specialties and when you go into some of the things that are there for physicians today, many are not choosing primary care. Primary care physicians, as far as compensation, are on the low end of the scale. And so a lot of the young people today are looking more at quality of life. They're looking that they don't want to be on call, and they want to have a life but also be a good physician. So they're going into other specialties. So increasing the number of primary care physicians is difficult. And another thing that makes it even more difficult is then how do you look at other specialties, and I'm not talking about physicians, but we're going to expand down and have physician assistants. And if we have physician assistants, what are we going to allow them to do? You get into state law that each state is different. I know some states like Montana where, physician assistants can do a lot more than, say, here in Texas. So it's a real balancing act. And Robert, you may want to comment on it being a physician, but primary care physician is a serious issue. We have a real shortage.
Okay, thank you.
Yeah, I agree. I think there are ways to fix it. One way would be to pay them better, which would not surprisingly attract more people to those specialties. One simple thing we could have done, and I actually thought we were going to do this, would be to either forgive student loans for people going into primary care, or at least make them interest-free. That's a huge incentive because the cost of medical education is mind-boggling these days. And as somebody who did it when it wasn't, sometimes you're glad you're old. And as far as the hospital, hospitals will look very different in the future. They'll be smaller. Emergency departments hopefully will be smaller. They will scale down to preserve, the margin they need to preserve. It'll take time, but over time, it would not be a bad thing at all to have people getting preventive and wellness care at a doctor's office instead of going to the emergency department. That would be a very great
I
thing.
think healthcare, as we know it, is totally going to change.
It'll be different.
Since the tax credit is less than the cost, what prevents an employer from downsizing to meet the smaller employee qualification? That's how do you prevent somebody from cheating on their income tax?
Well, it depends on the business. I mean, if you need a certain number of employees to really run your business, if you can just drop that many employees at the drop of a hat, then perhaps you're operating kind of in a cloud. I don't see how that's really going to happen, but, you know, I think in the newspaper there was an article about a gentleman who was thinking about going across the border just to avoid paying the insurance premiums.
Right.
So there will be some ramifications in the market.
Absolutely. What if an employer has been giving their employees a medical supplement in lieu of insurance? Does he qualify for a tax credit? That's probably a CPA question.
Well, to answer that again, it has to be qualified arrangements and with premiums paid. So even though there is a supplement, that would not qualify.
And at some point, they're going to define your particular plan, and you might have to wind up paying a penalty if you're providing a Cadillac plan or something, what they deem as a better plan. So that might affect at some point after 2014.
Want the tax credits for health insurance premiums based on salary incentives incentivize employers to keep wages low to save on the health insurance cost? That's the first question. The second is, what about part-time employees less than 30 hours?
Well, the rule was that they consider you a full-time employee for 30 hours. So if they're less than 30, then insurance premiums really wouldn't be an issue in that instance, unless the employer really wanted to be a sugar daddy or a sugar mama.
Well, and I guess that's kind of the big $5,000 question out there in terms of if you're a growing business, with these type of programs, disincent you from hiring that 10th person, or moving your people from 29 hours or 20 hours to 30. There's a lot of studies out there that said it will. But then, the other side is, well, if you're having the business, you need it, at some point you're going to hit that threshold. So that's just something nobody could really put an answer on it, but there's arguments either way.
The healthcare, if I understand it correctly, the Act calls for in the group environment. Now the employer has to pay at least 50% of the employee-only cost. And that's going up to 65%, as I understand it.
Really? How can insurance companies pay for increased requirements covering pre-existing conditions, no lifetime cap, etc., without raising premiums to unreasonable levels?
There's only one way you can do that, and that's to get everybody to participate, and that's what this law is attempting to do, is attempting to force everybody to participate. That's the only way that guarantee issue can work. If the Supreme Court determines that the law is, the mandate is unconstitutional, therefore people can't be taxed or can't be forced to participate, but yet the insurers are required to guarantee issue coverage, there's going to be almost every insurer is going to have to get out of business. It's not going to work.
Yeah. If the purpose of the act that we're talking about was to make health care affordable, how does this bill reduce the cost of health care? And again, probably by having everybody covered.
That's a great question.
It's a real good question. I'll tell you the answer that I've been told, and I'm not saying I fully agree, is you ramp up coverage and hopefully over a period of time access. And as the insurance folks said, you get everyone covered and you do better preventive. In the long run, it's supposed to reduce costs. But actuarially, I've never seen a report to substantiate that.
As a healthcare consumer, it strikes me that too large a portion of healthcare payments goes to administration of health records. What is the strategy of service providers to reduce their seemingly overly burdensome costs to providers, streamline the process, and leveraging the population to get better cost?
We'll all have a different perspective on that, I assume. You know, from the hospital or physician standpoint, it doesn't seem to me that there's been a whole lot of cooperation among insurance companies, electronic health record providers. You know, those things don't talk to each other. And forms are not standardized, and so it creates a big administrative burden. It does. Now, to be fair, hospitals haven't done all they can do to streamline their administrative registration and billing processes either. And so we're probably all guilty on that front. But there really hasn't been any major incentive to do it. And, you know, incentive usually means money or equally bad, probably regulation, and there really hasn't been any. And I guess this is a non-political discussion, but there hasn't been any political will to impose that, because it'd be a major controversy if they tried to do that.
You know, where the rubber meets the road is how many times you see a new doctor and you have to fill out all those forms, how many medications you're taking, over and over and over and over, how many times, unless you're within that same specific network. And so there's been a lot of laws that were passed, HIPAA rules and stuff like that were supposed to make it easier. It's, as they say, it's just not happening.
So the real question may be, do you believe the federal government can do a better job at reducing administrative costs?
That's kind of self-evident, right? When you state that the uninsured level in Texas is 30%, what is the population of the base? Is it just citizens and legal immigrants, or is it whoever shows up at the hospital?
It's the actual census population. That's what that's based on, that 27%. But it's actually higher, and let me tell you why. And Robin talked on this. When a patient presents themselves at the emergency room, and it's truly an emergency, and I don't want to use an acronym, but I will. It's called EMTALA. We have to treat them, and we don't discriminate in any way, regardless of their ability to pay, and we certainly don't check their U.S. citizenship status in the emergency room. We treat them, because that's what we're there for.
Is that going to change?
It's going to be tough. I mean, unless the federal law changes. I mean, it's going to be very tough. If you've got a true emergency or a trauma situation, how are you going to take time to try to verify this person's a U.S. citizen when you're there trying to render emergency treatment?
Exactly.
Well, my question would be, do we really want to? It'd be a question for the audience. Is that the kind of country you want to live in?
No.
The answer is no, I hope. I mean, I can tell you as a doctor, I don't ever want to practice that kind of medicine. I mean, you do what you have to do, and, you know, illegal immigration is a tough problem, but from a medical standpoint, patients who need to be cared for get cared for. I think that's what we want.
And you don't get reimbursed?
None, zero.
Yeah, if they don't make it true. That's what I'm saying, that statistic's actually higher, but this is measured based on the census.
Thank you. What is in the ACA to give doctors incentive to participate and accept patients with certain health insurance? Will doctors be paid a standard fee regardless of patient's insurance company?
You know, I'm, despite the fact that I'm on this panel, I'm no expert in all the intricacies of the ACA, but there's nothing in there that I'm aware of that standardizes payment levels. Now, Medicare has always been a relatively standardized payment system, and so that's not going to change, but I assume that based on the insurance exchanges, there's not going to be standardization of the reimbursement. It'll be based on the insurance company that they have insurance with, as it is now.
And like you said, the MRI can be different costs depending on where you go.
What did you say?
MRI, you were saying.
Oh, yeah, absolutely.
You know, the other thing, if I could add, and I'd love to get the insurance people's response, if you buy life insurance, you usually take a physical, and you get rated. And I'm not suggesting this, but, you know, sometimes it could well be that, depending on how you go, that insurance companies may have to rate you on health insurance. And in some way it's done. You know, there are a lot of employers now, if you don't smoke, you get a credit. If you exercise, if you have routine blood pressure checks, etc., trying to incent people to do that. But it could be that it will come to that sometime.
Well, the Act actually specifically prohibits any kind of underwriting in 2014. So I could be riding in an ambulance on the way to the hospital, call Bill, buy insurance before I get there. And literally, that's kind of how it would work.
Of course, there is the thinking that they'll manage it through open enrollments, but to a large degree that can happen. I mean, you can be diagnosed with a serious condition and, you know, within a brief period of time, and not have insurance and then purchase insurance.
Well, it's much like automobile insurance. And if you have a lot of tickets or a bad driving record, then your automobile insurance rate goes up. How does the Act affect Medicare eligible individuals?
To my knowledge, it goes back to what Robert said. From an eligibility and participation agreement for Medicare, it has no impact. Now, I will tell you on Medicare eligibility, it didn't pass in this middle class tax relief job creation. I think you will see the eligibility age for Medicare pushed to 67 or 68 sometime. I don't know when it'll be, and it'll be a phase-in period, but eligibility, I think, is the same.
Okay.
The coverage increase that we're talking about is more in the Medicaid area than the Medicare area.
I see, okay. Does everyone understand the difference between Medicare and Medicaid? Medicare is for elderly or older people.
And disabled.
And
And Medicaid is for,
in Texas, it's for children, pregnant women, and disabled adults.
okay, thank you. How does it work for state retirees to be forced out of Medicare and into insurance company coverage?
I'm not aware.
So they're going from the retiree coverage, which is an insurance coverage program, basically,
That's what it
being
said. To be
forced off that program.
out of Medicare and into insurance company coverage.
Must be talking Medicare Advantage or something like that.
Could be.
I'm not sure there's any provision to force people to do that. I think you can do that by choice.
Are the insurance carriers controlled from limiting coverage and increasing premiums? Can you raise your premiums anytime you want to, or is it a controlled environment?
No, we've never been able to do that. Insurance companies always have to get approval by the Texas, in our case, the Texas Department of Insurance. All premiums have to be approved by Texas Department of Insurance. There's an assumption that moving forward, and once the law takes full impact, that HHS will have to then get involved and approve all rate increases.
That's Health and Human Services. Well, that's actually all of our questions this evening. Gentlemen, I want to thank you very, very much for your participation and your knowledge this evening, taking your time, effort, energy, knowledge for coming. I thank every one of you for participating and joining us. I think you've got a couple of announcements.
Yes, Mr. GOREE has a presentation to make on behalf of the Hispanic Chamber and the Black Chamber to our panelists.
We want to thank you, gentlemen, for coming out. We know it's been, as I say, it's clear as mud. But that's why you have about 25 states that say the Supreme Court is going to look at this. 25, 26 states are suing the federal government because of this law. So we'll know probably in June or July what's going to happen. But nevertheless, we thank you for coming out, and we want to give you all a gift. Bob with the Boston Celtics. Dr. SCHWAB, Lewis. Thank you. I appreciate you for coming
Let's
out.
give them a round of applause.
Part two will be sometime in May. We do not have a date yet, but watch the newspaper and watch your emails and keep your ear to the ground, and we'll have a follow-up on part two sometime in May.
We have a few announcements to make. You know, this Healthcare Act is being looked at from various perspectives. Okay? The healthcare is being looked at from those that are currently uninsured. It's being looked at from those that are currently insured. It's being looked at from the insurance industry. It's being looked at from the hospitals. Okay? And then the physicians that serve our community. So everyone's looking at this act and how can this one act satisfy everyone? It's very, very difficult. So our goal in doing this presentation was to at least let you wade into the water, give you something to go home with and study, and then contact your elected officials about the things you like and about the things you don't like and the things that you need to change. And we're greatly appreciative of you coming out tonight. And I think Reggie was going to talk about an upcoming event that we're having on March the 10th.
I would also like to double say thank you very much to our sponsors, University of North Texas, DATCU, and the Denton Public Library. And we thank you very, very much for your willingness to participate this evening.
Okay, I'm here for behalf of the Denton Black Chamber of Commerce, and we're going to have a banquet next Saturday, March the 10th, 2012. And the speaker will be Russell Merriman, who's from the Dallas Cowboys. Very good speaker. I heard he's really nice, really good speaker and everything. And I think it starts at 6 o'clock. Is that right, John?
We have a VIP session from 5 to 6, and then the actual banquet will be 6:30 to 9. And he's going to talk about the business of sports. So he's going to talk about sports as a business. He won 3 Super Bowls. He was a 2-time NCAA champ, and he was also the very first player drafted in the 1991 football draft. He has a plethora of experience. He's a young man that got his college degree. He has a special message for young people, and we hope that people will come out and spend some time with Russell and break some bread and fellowship with him.
And the tickets will be available at Lone Star Car Wash, which is my business. Number is 940-565. I know a lot of dirty cars right here too. Don't go to competition. I want to take it. KERRY GOREE State Farm Insurance. His number is 940-382-9100. And I'm John BAINES, PC, CPAs. 940-565-9015. So if you want to buy tickets, just come to our locations.
And Reggie,
take care.
What's the location of the banquet?
It'll be in the UNT Gateway Center.
And let's give our moderator, Barbara Gailey, a round of applause.
Wait. And our website is www.dentonblackchamber.org.
But Mr. John BAINES is the gentleman who really kind of pulled everything together. So thank you very much for coming this evening, and we hope to see you in May.
And see you in May. Thank you very much.